Good morning, all. Lovely to see you, and welcome to you. And fantastic to see you at Social Club this morning. I did bring the banner, but this is Social Club in case you're not sure you're in the right place. Thanks. So a few thanks today before I get going. I want to obviously thank Hansons who are giving us this space today to use. I also want to particularly thank Graham Trigg, who's from Hansons, who's set this all up to. This is our debut as a webinar. We are web enabled, so we've got some club members all over the country looking in on the webinar, which is successfully running. So Graham's sort of moved heaven and earth to make that happen. So thank you very, very much.
You're welcome.
And we've also got our I think colleagues in Manchester as well. Watching as well. So we're a larger group than we look, basically. So what we're doing today, well, the format for this, for those that aren't familiar, is that we're going to hear a second from Paul Jansen from Buurtzorg in the UK, and he's going to be talking about basically Buurtzorg in Britain and how that works as a model, and we'll talk more about that in a minute. Paul's going to talk for maybe 25 minutes, something like that, and then we're going to open a facilitating conversation about what Paul's bringing to the conversation today. So that's what we're going to do, and then we'll run probably until about 10 o'clock, something like that, and then you can all run back to your offices and back to your desk. That's the plan. I know one or two people are going to leave early. That's fine. Just whenever you need to. Before we start properly, I just want to, really for Paul's benefit, but also for one or two other people's, if we could just do a quick round of introductions and just say our name, our organisation, and one thing that we're excited about today of all days is this lovely late November day. One thing that's exciting us about the day ahead. So I'm going to go from sort of left. I'm going to go from left round the room. So I'm going to start with my good friend Joseph Hans. Do you want to just introduce yourself, name, organisation, one thing you're excited about today? Yeah, just today.
So my name's Joe Howes. I've just started as Chief Executive 2 months ago after the UK. And today I'm just excited about hearing new ideas, first Chief Exec role, so getting new ideas out there and hearing about
Lovely. Thank you, Joe. Let's sweep round in and carry in that lovely
Morning, managing now I work for an organisation called Tempo, called Time Credits. I'm interested to hear Paul speak about this. I've read a little bit about it and just see whether there's any application for what we do.
Thank you, Ian.
I'm Neil Woodbridge. I'm the Chief Executive of Thurrock Lifestyle Solutions, supporting people to live in the community. And in terms of my excitement about today, Thurrock has flirted with this model for a while. I'm quite keen to progress it and quite looking forward to getting some ideas from Paul.
Thank you, Neil.
Nicola Brittle from Affinity Trust. We support people with learning disabilities. Just excited to hear more about this model.
Thank you, Nicola.
And Richard Parks, Managing Director for Young Landlord Cooperative. I'm excited every day.
Thank you.
My name is Ralph Purnell. I'm chair of Bromley Healthcare, a community healthcare organisation. What I'm excited about today is I don't give a stuff what happens with politicians and Brexit. We will overcome.
Very good.
Hi, I'm Sat. I'm the CEO of the Renaissance Foundation. It's a specialist youth charity that we focus on supporting young carers, young hospital patients who have specialist needs, and then also pupils at risk. And I'm excited to be back here because I had a crazy 6 months of reorganising things. So it's nice to always get a breath of fresh air and hearing. It's a unique forum to get similar challenges that I think people at leadership level where you have to have an answer for everything. Sometimes you don't. So I'm excited to come back.
Thanks, Sat. Thank you.
Mervyn Kay, COD First. We provide youth services currently for Revolution, as he knows thereafter. I'm excited we've got the mayor coming down this evening with some children, so a good drive away. It's exciting.
Yeah, absolutely. Thank you.
I'm Ian Hempseed from Hempstead's. I'm the head of charity and social enterprise here. I'm also a trustee of Part of Change, which supports community businesses. So I'm very interested in another version of what a community business might be.
Thank you, Ian.
Nadine Zahn. I'm an associate here in the Charities and Social Enterprise team. What I'm interested in today is to hear more about Buurtzorg and nurse-led delivery in particular, and how that really works with changing attitudes to management and how we go about that.
Thank you, Nadine.
I'm Andy Brady. I'm course leader for Charity and Social Enterprise at Anglia Ruskin University in Shepperdsford, and looking through the slides, I'm excited. Universities are quite hierarchical and rigid bureaucracies at times, and the intriguing notion of professionals in self-organised teams is one that appeals to me more in a general management kind of way, rather than the specifics of health.
Thank you, Andy.
I'm Judith Brady. I'm a freelance consultant at Interim. I'm currently interim CEO of Bond, which is the membership body for international development charities. What am I excited about today? Really excited to hear about what Paul's going to say. The state of health and social care currently grieves me, particularly social care, and some sort of grain of comfort that there's stuff we can still do to make things better. I think it will hope be great. Apart from that, my kitchen got finished yesterday after 5 months. 5 months, that's actually nice.
Very good. Thank you.
Ben, right, I'm Ben Freeman from Bubble Chamber. I'm excited about two things. One is I've had a cold for the last 4 days. I'm feeling better, which is very nice. And also just hearing about movements and how you get swathes of people to behave in a different way.
Thank you, Ben.
Another Ben. I'm Ben. I'm Chief Executive of an organisation called BDSIP. We provide a range of professional support services to schools around work experience, careers, school improvement, SEN, inclusion, attendance, all those kinds of things. What am I excited about today? I feel like I've spent the last month up to about here in kind of operationalness. So I'm really looking forward to a morning that kind of helps to lift the horizons and get me back into a thinking space so that I can go home this afternoon, recharge and with some fresh ideas to kind of work on our business plan from a more strategic perspective, and less one that's concerned with the niceties of what ended up in our articles of association, etc.
Thank you, Ben. That's great.
Hi, I'm Graham Trigg. I'm head of client services here at Hempsons. I'm excited for lots of reasons. The webinar is very exciting, very worrying. I'm also excited because I've seen the slides already.
Thank you, and thank you all. So on Paul, I've known Paul since about 2012. We've worked together for many years within Stepping Out, which is my other thing, and so we've both shared a real interest in health and social care. Paul moved to Buurtzorg essentially a year or two ago. I've been watching with interest since, so we caught up recently, and I thought you've got a course of social club, you've got a talk to story. So without further ado, Paul, over to you. Thank you very much. Welcome to Social Club.
Thank you. Well, I'm very honoured to have been invited. I've seen which kind of other speakers you've had so far, so to be in that illustrious company is quite impressive. I don't always wear an earpiece. This is a part of the technological setup for today. And I don't always stand to the side of the room, but I think that's all part of making sure that people can hear and people can see me, and I'm sure Graham will tell me if I do something wrong. But a little bit about me before I kick off. Today I want to tell you about Buurtzorg and how it came about in the Netherlands, and then move on the story, what that means for the UK, what we are doing in the UK, and how we believe it might actually also benefit the UK health and social care context. A little bit about me, as you will have picked up, some of you already know, I am from Holland originally. I have been in the UK for now 21 years, but I'm sure you can still pick it up from my accent. The benefit of that is, of course, that I'm the only one who can actually pronounce Buurtzorg properly, which is one of the main reasons why I got the job. Just to explain, buurt means neighborhood, zorg means care. So Buurtzorg is very much a neighborhood care based model, and I'm going to tell you how that all hangs together. Before I start the PowerPoint barrage, I'm going to show a little video that gives a flavor of the organization and how it came about, and also how it might compare with the UK. So this one.
Maar wij zetten vanavond het zoeklicht op het inspirerende verhaal van Buurtzorg. 9000 werknemers en niet één manager.
Je kreeg steeds meer Managers. Ging er iets mis, dan werd er wel iemand opgezet. Ging de planning niet goed, kwam er een planner bij.
Jos besluit samen met zijn vrouw dat het anders moet en kan. Hij wil wijkteams samenstellen die zelf de zorg voor de patiënten regelen. Geen planner, geen manager. Het team regelt alles zelfstandig. En er is geen hiërarchie.
Veel mensen denken dat je alleen met het ingewikkelde organisaties iets voor elkaar kan krijgen. En wat wij zeggen is nou, hoe minder je organiseert, hoe beter.
Morning.
Morning.
How you doing?
Yeah, fine,
Very good.
Goedemorgen. Geen gekke foutmeldingen of zo meer gehad?
Ja, vorige week nog een keer.
Ja.
Maar de volgende dag deed hij het.
En u hebt er niks aan gedaan?
Ik niet.
Hebben ze het vanuit het ziekenhuis
Ik zit al wat op
misschien?
de knopje te drukken dat hij uitgaat.
Ik denk dat ze het vanuit het ziekenhuis hebben kunnen regelen.
I just want to check your blood pressure first, okay, Stanley? So we find it a little bit exhausting sometimes. Sometimes we do it triplicate. We keep notes here, notes in the office, and then we have to put it onto Rio, which is an electronic computerized system. If I had the tablet here now, I could be inputting it all together, and then that would be it all day. But it's 3 times we're having to input the same information, and you can guarantee this information is not going to be exactly the same as it was when you first was started off from the beginning.
Dit is het systeem waarin wij onze zorgplannen maken. En al mijn collega's die kunnen hier ook op kijken en waar we de rapportages ook in zetten. Controles die doen we elke dag, de bloeddruk meten en het gewicht meten. Zodat we ook heel snel kunnen zien of er iets verandert in het gewicht, of meneer vocht vasthoudt, of dat de bloeddruk heel erg gaat schommelen. En daarnaast gaan de controles gelijk rechtstreeks via de smartphone naar het ziekenhuis.
I went to Buurtzorg in Holland to see how they actually did things. I found it very enlightening. Went out with a nurse who took us out to see various patients. She actually did the personal care, medication, the food, and anything else, empty the catheter bag, anything that was needed to make that person kept comfortable. Now, that way of nursing, to me, was how we used to do things years ago in the community, where you did all the personal care, dressings, anything that was needed for that patient, we actually did it. But then, years down the line, that was taken away from us.
As a senior nurse, what I would like to see as a key improvement in exploring this model is closer working between health and social care. So one of the really inspiring things that I saw over in Holland was when the nurse went in to visit patients, she did a whole holistic package of care rather than just doing one part and then another organisation comes in to do a different part.
Right, so I hope this gave you a bit of a flavour. It's didn't have any windmills or tulips, but hopefully it showed you a little bit about what it's all about. So why did Buurtzorg come about? Back in 2006, Jos de Blok, the founder of Buurtzorg, together with his co-founders, they were all operating in the world of health and care in the Netherlands, and they were increasingly frustrated with the way care was organized. It was very much based on this scientific management principle of, as long as I can allocate the cheapest resource to the least complicated task and build up my care package and my care, the way I organize care that way, then the care will be delivered in the most efficient way possible. Nice in theory, but people who need care are not the same as building cars. And he increasingly found that actually, despite the expectation that that would lead to a very efficient way of delivering care, he saw that the costs were spiraling. And he also noticed that no party involved in delivering or actually receiving their care was particularly satisfied. Patients were unhappy. They were constantly complaining about the fact that care was not of good quality, that they saw 3, 4, 5 different people coming through the door every single day, delivering a different aspect of their care needs, probably another 3, 4, or 5 the next day and the next day. But also care professionals themselves were very frustrated. They could never respond really to a changing request of their client. They didn't have time to sit down for a conversation and find out actually whether their contribution and support was doing the right thing for their clients. So actually nobody was really happy. And Jos, who is of origin a district nurse, felt that actually that model that is also referred to in the video of 20 years before, where district nursing was very much based on small teams that sorted everything out themselves, he actually wondered whether there was a possibility to reintroduce that model in a different sort of modern guise. And that's what he decided to do. He essentially did not start from the concept of let's create self-managing teams, even though Buurtzorg is probably usually encapsulated by that phrase, oh yes, Buurtzorg, the organization with self-managed teams and no managers, and there is definitely an element of truth in that. But that was not the starting point. The organizational model of Buurtzorg is a consequence of their care model. Their care model is very much what I'm trying to show here in this, what they call the onion model, having relentless focus on the patient and really have the patient or the client, as Buurtzorg call them, at the center of everything they do. Now, every care organization, I'm sure, present or not present today, will say, oh yes, we have the client, the patient at the core of what we do. I think Buurtzorg definitely have redefined what that means. And we'll explore a little bit what that's like. I will be going at a rate of knots, by the way, this morning. I can talk about this stuff all day, but we can certainly address lots of questions that hopefully this will provoke. So the patient at the center, but also looking not just at the patient, him or herself, but also at the people surrounding this patient. And can we give the informal network, as we call that in Buurtzorg, can we give that an important role in how this patient can actually live their life independently? It's only then when the Buurtzorg team as care professionals come into play, and the Buurtzorg team see themselves really as the care coordinator that help navigate the health and care system with the patient and get involved with other healthcare professionals and other parts of the system and that may not be about healthcare at all. And by the way, I talk a lot about nurses, but we'll see that actually the scope of work involved is actually much broader than that. So in UK parlance, we're talking personal care as well as healthcare here. So the client at the center, what does that mean in Buurtzorg? It means that when a Buurtzorg care professional comes into the house of a new client, that the first thing they do is not to find out what their disease is or their condition. No, they find out who is this person. First coffee, then care. So let's first invest a lot of time in understanding who this person is, what their priorities are, what their life is like or has been like, and what they really want to achieve with the support that Buurtzorg is offering, but also what they can do themselves. Buurtzorg work with a huge range of clients, mostly elderly, of course. That's by definition the kind of client group that you will encounter in home care, as I'm sure you are aware. But they could also be younger people, could even be children. And they could be people coming just out of hospital and need some support with recovery. But they could also be people with a long-term chronic need, or they could be people in an end-of-life situation. And all of that is taken care of by Buurtzorg teams. And what they do is they look at the holistic approach, as we say. So we don't just look at the condition. We look at also maybe the mental health needs of the person in addition to the physical need. We look at whether the relationship issues perhaps that play a role in all of this, etc., etc. So there's a very broad picture being created about who this person is and where Buurtzorg teams can actually help them get back on their feet. In Buurtzorg, there will always be only essentially one or at the most two care coordinators for that particular client, and maybe one or two other ones from the team that will provide the care needs of this person. And this will be the whole range of care and support needs. So although these nurses will be highly qualified, or they will have higher qualifications than your average home care worker, they will actually do a lot of home care work as well. So they will actually come in, help the person get up in the morning, have a shower, get dressed, look after their healthcare needs, whether it's dressing of a wound or looking after, giving medication, whatever their healthcare need might be, maybe helping with feeding and things like that. So that means that there's a huge range delivered by just the one person, as you partly saw in that video. And that means also, in addition to the time invested, that you really begin to build a relationship up with the client, and that the nurse can actually see very subtle changes in what the client needs very, very quickly, and can either check, for instance, the skin condition on a client and intervene really quickly before actually some wound might actually start to appear. So there's a lot of prevention in that sense. It might be around, oh, this client is today a bit unstable on her feet today. What's going on? Let's find out, let's explore further and address that need. And the nurse has the freedom to spend more time with his client there and then, doesn't have to go back to head office and ask for permission or any sort of manager, simply address what's needed. And that has really resulted in a great level of client satisfaction and also very good health outcomes. Now, the other aspect of the Buurtzorg way of delivering care is really focusing on self-reliance and independence. And this is also where this is where partially the nurse's contribution comes into. So what can the patient do, him or herself? What does she need help with? Do I perhaps need to teach the client about her condition? Is she showing the right behaviors in addition to actually helping resolve a particular health or support need? So that perhaps today I'm investing a lot of time in training someone up in administering eye drops or putting on support stockings, and it costs me a lot of time today. I can probably do it much quicker myself, if as nurse. But actually, in 1 or 2 weeks' time, this patient can take care of herself, and I don't have to come anymore. That's the whole point. And looking at the role of informal carers in that is therefore then a logical next step, right? You work with a partner, children, neighbors, but also voluntary sector, a church group, whatever the nurse can find in the environment of the client that might help in actually regaining that independence. So it's only then that you begin to realize that having small local teams who understand the local infrastructure, who understand the local players, sources, resources, makes an awful lot of sense, right? It makes sense then also that if you want to give this care professional the freedom to tweak and flex the day and how they administer and how much time they give in their care to their client, it makes sense that you therefore give this care professional or this group of care professionals a lot more freedoms than just that. You give them the freedom to plan, you give them the freedom to organize, and actually once you start thinking that through, it makes a lot of sense to think about how far can I let this self-management concept go with that small local team. So local is important and small is important really because it's and there's plenty of studies that evidence this, that up to about 12 people or so, coordination is very easy. Beyond that, it becomes difficult. You need more systems, you need more layers, you need more stuff to get people to understand what's going on. So keeping it small and keeping it simple is therefore a crucial element of making these teams locally work and allowing them to get on with it. But it means that you have to trust that these professionals are professionals, that they've been trained up and they know what they're doing, right? So you need to trust them to get on with stuff and not second guess what they need or what their clients might need. So it's really important that you allow them to do their work. And therefore Buurtzorg is based on a model that says people generally come in to do a good job. 98, 99% of the workforce, they've gone into care because they really want to care. And therefore, do we need to impose an awful lot of rules and policies and procedures and guidelines to capture that 1%, which, by the way, you don't really capture because stuff still happens, right? Things still go wrong despite all your policies and your procedure manuals. Actually, Buurtzorg has turned this on its head and said, right, I trust professionals to do the right thing. And by creating small local teams, I will nip things in the bud that perhaps will go wrong in practice. people will, because they trust each other, because they monitor each other, because the patients and care professionals understand each other and know each other, things are much less likely to spiral out of control than if you have a much more anonymous, larger organization. So small local teams, they organize a lot themselves. So when a new team is created in Buurtzorg, very often these are created by nurses themselves. They approach Buurtzorg and say, hey, in our patch there isn't a team yet. Can we start one? And the organization will start working with a group of nurses and get it up and running. And then teams will find their own office. They get a little budget for that from Buurtzorg and get on with it. And then these teams, they have, of course, a range of targets that they are asked to operate within. In Buurtzorg's case, they're asked to deliver 61% of their time as client-facing or chargeable time, because in the Netherlands you have an insurance-based health and care system. So that 61% guarantees that Buurtzorg as an organization is financially sustainable. They have a couple of other sort of boundary sets that make it clear within which range they can operate themselves. But for the rest, they can just get on with it. And they're being supported by only 50 people in the back office for an organization of 14,000 people, who just focus on the question, whatever I ask my teams, how does that support them in delivering better care? So they don't second guess, they don't control, they don't ask for all sorts of stuff that they think might be useful, they don't impose anything, they only respond, and they try and keep away stuff that interferes with frontline workers doing frontline work. But as self-managed teams, of course, you will have sometimes things that you've never encountered before that you need to learn. You may have conflicts. Of course, how do you make decision in a self-managed team, which in Buurtzorg is very much based on consensus? So how do you do that, and how do you make sure that you don't get stuck? Well, Buurtzorg has some methods for that. It's called the solution-driven method of interaction, which is very sort of solution-focused, as the name gives away. But they also provide coaches. So the whole organization has 20 coaches on about 1,000 teams. So that's about 50 teams per coach. And the coaches are there to respond to requests from teams about what they struggle with. So it could be performance, it could be a conflict, it could be a non-performing colleague, it could be all sorts of things, whatever it is. But ideally, or in principle, the coach is not there to make decisions, to tell teams what to do, to castigate them for perhaps struggling to meet certain targets, etc. And finally, and that's the benefit, of course, of the modern day, all of this is supported by a clever piece of kit. You saw some of that already on the video. Largely focused again on supporting the care professional in delivering the care that they're asked to deliver. So a very clever tool that really cuts away or does away with a lot of the stuff that care professionals often encounter in their computer systems. Really focused on the journey that clients have with them, outcome focused, helping them to set personal objectives for clients, helping them to identify indeed not just how do I deliver care, but also what training can I deliver, how can I help my client to change their behaviors, etc. But it also supports in very pragmatic ways and with team planning and communication, etc. And of course, if you're a self-managed team, you also want to have a tool that tells you how you're doing, right? So again, this tool gives a bit of a dashboard that allows teams to sit down on a regular basis and ask themselves, okay, are we still delivering good care? How we're doing on these various targets? Should we focus on a particular area where perhaps we're struggling a bit, and how we're going to do that? And should we perhaps ask the coach to come in and help us with that particular aspect? The kit also provides a client portal, so clients and their trusted person or persons can have direct access to their own records, can also, through the tool, communicate directly with the team. But of course, they can also just pick up the phone. I mean, that's the benefit of having a small local team. When you pick up the phone and dial the team's number, you get the person who you know, and it's not some anonymous call center or client service department that will take your call and will pass on the message or not. And finally, the tool or the infrastructure that Buurtzorg provides, it's a bit like an internal Facebook as well. And that's important when you have all these independent, self-managed teams, that you also address this aspect of how you bring the organization together. And Buurtzorg is clearly comfortable with allowing teams to find local solutions for their own local situation. But you do want to have some organizational learning, and you want to also benefit from expertise that sits elsewhere in the organization. So for that, there is this internal Facebook through which Jos communicates with the rest of the organization, sometimes on very big and important matters. So he might simply ask questions of the organization: we're dealing with this issue, what do you think? But there are also very pragmatic things around, okay, so who are the specialists on end-of-life care in the various teams? I'm in a team where I have a particular problem with a patient who is in that stage of life, and who can help me in my environment? Well, you can see on your tool very quickly whether there's a specialist in the area that you can call upon from another team. But of course, there's also e-learning on that tool and all things like that. And finally, the back office, of course, uses all this data to satisfy the regulators, to bill the care delivered to the insurance companies, and to pay their staff. Quite important. So, as I'm sure some of you have picked up already before, Buurtzorg became quite well known very quickly because it delivered great outcomes. Patients absolutely loved the way they were receiving care in this new model, and that word spread really, really quickly. And also, care professionals loved working in this way, and that meant that, of course, some of the other organizations in the Netherlands wondered, you know, what's the secret of the success, if they were coming from a positive angle, or slightly more cynical, you know, what's really going on there? There must be a catch. So there were some independent verification exercises started, and KPMG and Ernst & Young did separate studies in different stages, actually evidencing that the care was significantly cheaper delivered in this way, and also that outcomes were significantly better, and that patients were significantly happier with the care that they were provided with. So what's the business case behind Buurtzorg, in short? Although Buurtzorg employs higher qualified personnel than your average care organization, there's five nursing levels in the Netherlands, nursing and care levels, I should say, and they only employ levels 3, 4, and 5, so the three highest levels, and they pay them slightly above market rate as well. That will result in a higher cost per hour of care, right? So how can this model then be cheaper ultimately? Well, that's the first stage, is around that care strategy that hopefully you've now got a little bit of a grasp of. By focusing on improved self-reliance, and by using this informal network, you actually start to get the need for a much shorter care episodes per client. So cost per client is actually reduced because of that, first and foremost. And secondly, because your organization all of a sudden doesn't need all sorts of layers of management and control and communication and that sort of thing. You have a back office that only costs 8% in terms of overheads, compared to your average organization spending 25% on overheads. You see a massive cost improvement going on there, right? So the organizational strategy is the second whammy in terms of cost savings. And then thirdly, but that's not ultimately ending up in the reserves of Buurtzorg, because people receive better care in the home, they present on fewer occasions to GP surgeries, they present fewer to hospitals, and in all sorts of aspects, actually, they have a lower demand of the rest of the health and care system. And that's, of course, a benefit to the wider system, which may not end up in Buurtzorg coffers, but is ultimately still a good thing. And let's not forget, Buurtzorg is a not-for-profit organization. Jos started this not because he wanted to get rich quick. He started this because he believed there was a better model of care possible, and he wanted to get that out there. So Buurtzorg grew exponentially, really quickly. So one team in 2007, 1,000 teams almost today, almost throughout the entire country. But very quickly also internationally, there was a lot of interest in this model, and Buurtzorg has responded to that. There is no let's conquer the world strategy in Buurtzorg towers in Almelo of all places. No, all the activities abroad are in response to requests from people who really like this model, usually existing care organizations, but sometimes also startups who want to adopt this. And and there's a lot of international work going on now. From the US to Sweden to Australia to New Zealand, but also in China and India and Japan. And not just internationally, also nationally, Buurtzorg has influenced a lot around the health and care system, and has also introduced offshoots that are based on the similar principles in the core Buurtzorg service, but are focused on mental health, are focused on youth care. There is a hospice, there are care hotels, and all sorts of other things are springing up. And there are plenty of conversations being held with educators and lawyers, by the way, as well, and and other people who are intrigued by the model. I'm seeing Craig getting nervous, so I'm going to speed up even more. Very quickly then, experience from the UK. Again, in response to, you might recognize this house, by the way. It's an elderly couple living there, but they haven't quite asked us yet. Can the model work in existing organizations? Because that's one of the big questions, right? If you want to introduce this in another organization, can this also work, or can this only work for Buurtzorg because it was so specific and it started from scratch? What we are trying to do is find out whether you can have part of your traditional Christmas tree organization transformed into something that is much more akin to a self-managed organization. And our approach is that Buurtzorg is not a house of cards. This is not a take it or leave it kind of model, a McDonald's franchise with a God knows how many pages documented that you have to follow to the letter. It's much more of a Jenga. You can make adjustments to fit the local situation, and you will still get a lot of the good benefits. If you try to adjust it too much, of course, you do risk that it all comes crashing down. And finding that right balance is what we are working on a lot with our clients. We, Public World, who also now operate under the name Buurtzorg Britain and Ireland, we work as a small consultancy. We represent Buurtzorg here in the UK, and we therefore work with existing organizations predominantly who want to understand this model and then implement it. And as you can see from this map, partly obscured by our friends in Manchester, we've got various pilots going on around the country. These are not our teams. These are organizations who are our clients and have set up their own pilots with our support. And they tend to all have slightly different flavors. So some are very much that integrated health and care model that Buurtzorg really is all about. But some are focused more on the health side. Some are focused a little bit more on the home care side. There's one interesting model going on in Cambridgeshire, which is much more around the care navigator element of the need. But from each pilot comes an awful lot of learning. And what we try to do in that setup is to create a bubble in an existing organization where you can reboot almost, where you can reset the laws of physics and say, right, the normal organizational laws don't apply here. In this bubble, we will do things differently. We will do away with 500 policies, manuals. No, we will reset how teams are created, and we will reset how we interact with, or how the teams interact with clients and the rest of the organization. That means that you have to create a coach, or create a coach. You don't create a coach, but you have a coach with the teams. You support the teams in how they set up and how they come to decisions and all that sort of stuff that I touched upon earlier. But you also start working on the attitude of how the back office supports these teams. Rather than do on to your frontline staff, they have to really flip their mindset and start thinking about them as a client. How can I best support them at your service? And really try to do away with everything that is not essential. So keeping things small and simple. Now you will encounter problems when you start introducing this. So it's really important that you realize that before you start, and that you build a bit of an approach, call it agile, call it prototyping, call it what you want, but an approach essentially that means that, okay, we have to tweak this as we go along, and only once we have done a few iterations, we will probably have removed all the hurdles and all the sticky points that we find difficult to get around with. And then we are at a point where we can roll this out more widely in the organization. So to do this well, in summary, this is not just about self-managing teams. You really need to be able to trust the professional. If you as leader actually think, well, I still need my control systems, then don't do this. Don't start. You're not going to like what comes out of this. It will be a disaster. You have to really change your culture and repurpose the entire organization. So don't just create self-managing teams to say, right, guys, from now on, you're self-managed. Good luck. No, you have to look at the entire organization, what it means to them. And also look at your IT. Be relentless in simplifying everything that you do. But if the question from you is, as leader, how can I support this process in the best possible way? It's really to be visible and really support it in everything you do, both in your actions and in the words that you choose. So does this work in the UK? Because you might argue, oh, well, the Dutch are different, right? They are a bit more blunt. They wear clogs. No, they don't. Their communities are nicer to each other. Well, I can guarantee you there are many, many more similarities between the English and the Dutch than there are differences. And what we pick up from the pilots is exactly that actually these teams can deliver great care, and patients absolutely love the way they are being looked after. Patients here in the UK are also quite prepared to get more actively involved in their own care. Maybe, after a few nudges, but it's the same in the Netherlands. Not every client is saying, oh yes, what shall I do myself? No, there's plenty of people over there who initially say, well, I pay for you, so why don't you just deliver what I've hired you for? So great care, great outcomes, great jobs. Those pilot teams absolutely love working in this way, even though sometimes it's pretty tough. Performance managing is one of the harder ones. Conflicts in teams, sometimes not people pulling their weight. How do you deal with that as a team? Not easy, but overall they absolutely love working in this way. But the two questions we haven't quite answered yet from these pilots is, are these organizations able to change entirely and repurpose themselves? Are back offices and management layers able to actually let go and think of those frontline people as people that they really need to support rather than need to tell what to do? We're not there yet. And where we're not there yet either is, can we evidence that this leads to cheaper care? Because pilots are small, they have their own dynamics, and the financial evidence from that is of course, personally, I think you shouldn't do a pilot to evidence that. There's different ways of evidencing that. But anyway, from evaluations coming out of those pilots, we haven't quite got the evidence yet on that front. So I'm going to leave you with one of the wise words of one of the founders of Buurtzorg. And I'm very happy to take your questions.
Thank you, Paul. That was brilliant. Sure, of course. I'm confident there's going to be a lot of questions and comments. Just give Paul a breather. It might be just worth taking 2 or 3, and then giving Paul perhaps a chance just to reflect on what he's hearing before asking back on his feet to come back to you. So. Could put some over in a second. I suppose one reason I asked Paul today was one was my interest in health and care, but also this stuff is about every organisation, whatever business or sector we're in, and it goes right to the heart of how you approach management and leadership, which is why I thought it was so relevant to us today. So yeah, so I'm sure there'll be some thoughts from those not in social care as well. Mervyn.
Oh, that's great. Thank you. But in terms of the income model, how does that sort of match onto it? So the team's individually responsible in terms of if they don't raise the income. How does the centre support them in terms of cost versus income?
It's a question of income. And Andy Grady.
And the dynamic of teams, I'm quite interested in that. How is there a phenomenon where leaders emerge in those teams? Is there any studies done on that? And I'm interested as well in the role of gender in that process, and whether that skews things in terms of who thinks they're a leader, even though there are no leaders sometimes.
So how does leadership really work on a gender level?
Yep.
Thank you. And we'll have sat Neil and Ian, and then we'll give you some time to come back for.
Okay.
Yeah. Sat. If you speak as loud as you can, because our colleagues in Manchester are dependent on microphones here.
And so your talk was really interesting, and something that really stood out to me was about when things kind of don't go right. You mentioned that you have something called a solution method of interaction. That would be really handy if you have any tips on how to solve problems within teams, or just it sounded really interesting.
Yeah.
Neil, and then Ian, and then we'll.
Mine was about the role of the coaches. Can we just expand that a little bit about their sort of training and background, and a bit more about what that role actually is?
Then Ian, and then we'll like Paul.
It's a related question. How do you address individual poor performance?
So when things aren't going right, who sorts it? Yeah. Plenty to go for there, Paul. I think Are there any questions in Manchester?
Can you hear us?
Yeah. We can hear you well. Can you hear anything from this room?
Yeah. So it's Michael Langley from Manchester. I'm a partner in real estate team. My question is a lawyer's question, which is how does the Buurtzorg approach fit into the statutory and legal framework of care in the UK? Are there any impediments in the UK? You have to provide care in the Buurtzorg manner?
Thank you. So how does this fit into the way we finance and all the legislation on this? We've got something coming in from the webinar. Let's hear it. It's exciting.
And we have a question from David Osborne. Governance, how does the role of the board fit within the system?
Loads to go for there, Paul. Have a few minutes and find a way through that. Some of them are overlapping, I would hope, as well.
Yeah. Okay.
To come on your feet again as well might be better for audibility.
Yeah.
So
let's start with Murph's question about the income model. So in the Netherlands, as I alluded to, there is an insurance-based model for 96% of the care, the kind of care that Buurtzorg provides. Now, this talking about health insurance in the UK usually results in the sharp intake of breath. In Holland, they've used the insurance-based model really to allow individuals to determine the kind of care that they want and need, on top of a basic package of care that everybody will have access to. So all insurance companies, there are about 7 sizable ones in the Netherlands, they are obliged to take everybody on who approaches them as client. They can't turn people away. And on the flip side of that, insurance companies then have arrangements with all sorts of care providers, whether it's hospitals or GPs or physios, or in this case, community care organizations. Now, the kind of care that Buurtzorg provides, so community care or care in the home, is part of that basic package of care. So everybody has access to that in the Netherlands. That's first and foremost. So if I'm a person who needs care in the home, maybe my GP has told me, oh, you should contact a care organization, then I may make a quick phone call to my insurance company, and they might say, well, we got these 3, 4, 5 in your area, and pick the one that you like the most. That partly also therefore explains how Buurtzorg grew organically, almost bottom up from demand side. That means that for a Buurtzorg team, and I think that's where your question really went to, for a Buurtzorg team, it's important that they do sufficient work that they can charge back to the insurance company, and that's where the 61% sort of usually say client-facing time comes from as a target. At Buurtzorg, they've worked out that as long as our carers spend about 61% of their time on that, then we can run profitably as an organization. And actually, we don't want carers to spend significantly more time on that, because we also want them to have a good work-life balance. We want them to take time off regularly. We want to make sure that they invest in their own training and education. And as teams, we want them to spend sufficient time also on their team dynamics, but also in getting those links in the local community, making sure that they speak to the GP regularly and the physio and the OT and all that sort of stuff. In the Netherlands, there certainly was, and to a certain extent still is, a bit of a cost structure that isn't probably dissimilar to the UK's home care, domiciliary care system. There were lots of tariffs for different types of care delivered. So really that system of bar scanning at the door when you come in, oh, I'm washing a client, that's a tariff. Client washing, I bar scan again when I go out, and that will be billed to the insurance company. Now, Buurtzorg turned that on its head and said, right, we can't deliver care in this way, because it's care. Whatever it is, it's care. Whether it's washing or whether it's changing an IV, it's care, right? And so they had to battle hard over time to win that discussion with the health insurance companies and also with the state. But they did, and now these whole tariff systems have completely changed, and care is now expressed, care costs and tariffs are now expressed in hourly units. It means that for the carers and the teams, they don't really have to worry about any of that, other than that target of, am I delivering sufficient numbers of care? They don't have to worry about the breakdown. They don't have to worry about whether it's the cheaper, lower qualified nurse of the team or the higher qualified nurse of the team who's going there. They don't have to worry about any of that. All they have to worry about, do I hit my 61% client-facing time target? Does that answer your question?
Yeah, I mean, I think it does answer part of it, but given they're all teams, I'm kind of doing it in some ways, and this gets to maybe the question around the board as well. As a kind of almost franchise model, but not quite a franchise model, like McDonald's analogy. Yeah. So if the team is underperforming, either because they're underperforming or because they're not reacting, the market is there, and so they fall by the wayside. It's that relationship between the income generation of a small team and the central office. Do they charge back the central office to those teams?
No. First and foremost, all these staff are employees of Buurtzorg. Yeah, so they don't have, it's not a franchise, so let's be 100% clear about that. There's no internal cost charging going on. That doesn't add anything in the eyes of Buurtzorg. That's all just fluff. But of course, these very, and as I said, they have few very clear targets. If those targets ultimately are not met, first and foremost, it's down to the team. Why are we not meeting our targets? Guys, let's talk. What can we do else? Do we need to go out to the GPs more? Do we need to do some advertising locally? Do we need to organize some walk-in coffee mornings to, give some more familiarity to the fact that we exist? Once they struggle and can't really tackle that, they might call in the coach. You say, coach, we're really, really struggling here. What else can we do? So they work with the coach. If then over time they still struggle, then there will be a conversation about, okay, maybe this team is simply not viable. Maybe there's too much competition. Maybe the composition of the population has changed. Maybe that's the reason why the team isn't functioning. But it could also be, and that touches upon some of the other points, maybe internally there's all sorts of stuff going on. And maybe people don't like each other, can't arrive at good workable solutions in the team. And actually, that's what's really going on here. And that might also be a reason why teams ultimately can't get their act together. If over a long period of time, we're talking probably 3 to 6 months, teams can't really reach those kind of targets, then there may have to be a conversation about, well, shall we just disband the team, let team members go to other teams in surrounding areas, and leave that part of the market to other providers. So that does happen, and that's usually ultimately Jos's call, and it happens so rarely that you can have that kind of call being made at the very, very top because it hardly ever happens. So that was hopefully the income question. Something about teams and the team dynamics and the informal leadership, I think, is what you were asking, Andy, wasn't it? The team have that's one of the biggest pitfalls in a self-managed team. So how is a team composed? As I said, 3 levels of nurses, but the level really doesn't say anything about your authority within the team. The level says what you can do with the client. So if you're level 3, you're not to do the high-end clinical interventions, but you can do probably everything else. But within the team, everybody is equal. So when decisions are being made, what they need to do is reach consensus. And they're being trained and encouraged to reach consensus on the basis of not that this is always the best possible decision we've ever made, but actually that we can all live with this. So this SDMI, the solution-focused method of interaction, solution-driven method of interaction, helps them in doing it, and constantly have a conversation about, okay, what's the proposal? Is there an alternative proposal? Which one of those proposals are we all in support of, or at least we can live with, and we can try for the next month or 3 months, and then maybe revisit again. Now, sometimes, with all the best will in the world, this doesn't necessarily work. Or before I go into that, actually, there's another element of the teams. There are about 8 roles defined in the team. That could be the planner role. It could be the one that is the mentor for the younger members of staff. There's various roles out there. And they're being encouraged to rotate. So that you try to avoid somebody almost hogging a role that is perhaps slightly more important than another. You can imagine that the role of a planner can be quite important in driving how a team works and making sure that you never get the less favorable shifts, let's put it that way. So rotating those roles is really important. So there are a couple of methods and principles in these teams that are partly focused on avoiding the risk of getting informal leaders. Yeah.
Picking up on the leadership thing, it's great in terms of having that approach.
Yeah.
But you do anything around kind of Myers-Briggs kind of stuff? Because I can imagine if you had 10 INTPs, for example, you wouldn't get much done. You know what I mean? So you need to look at those personality things in bringing the teams together.
Yeah, you could do it, but you so don't. Yeah, it's an interesting theory. They have never gone down that route. But it's one that you could consider, I guess. Yeah. I think it wouldn't really fit in with the Buurtzorg theory to try and design all of this. They are much more about, okay, let things emerge and let good things happen. And if they are good and they work, so what? That they're slightly different in the next location or the next location. And
encounter much dysfunction across, because it all, originally a lot of places it usually not. Is it common to find dysfunctional behaviour and dysfunctional teams that are just really struggling in this kind of a model, or is it surprisingly successful? Do you find?
Well, if you look at some of the feedback on that, it is extremely rare. Otherwise, it wouldn't have been such a successful organization, I don't think. But when you speak to one of those regional coaches, she says, well, I look after about 50 teams. 45, I don't have to worry about at all. But maybe those other 5, they occupy 80% of my time because I am struggling. They are struggling, and they really need my help to get back on their feet. And sometimes, what I didn't mention yet, but I've got insider knowledge. My sister is a Buurtzorg nurse in the Netherlands, and she was in a team where there was one very dominant person, and she struggled with that. The rest of the team sort of just about could live with it, but she was really struggling with it. Tried to make it work, and after a year or two, said, "Actually, this is costing me too much energy. I'm going to move to another team." And that's what she did. Her original team is still ticking over nicely, and she loves working in her new team, and so there the problem is solved.
Which some may consider to be sexist, but is the reality of what I have personally experienced.
85% of our staff are female. They're in people's homes. They are very collaborative in the way that they deal with stuff. So some of these challenges that one can face in other environments, I found are wonderfully self-managed because of that instinctive, natural, or just the way that we are as a group of people who are involved in that type of care. So therefore, sometimes that may or may not be translatable to other environments where there's much more desire for male symbols of office and status. Now, angels fear to tread now, but I just do think there is something about care and the female element which is very helpful and very important in achieving this sort of model. Is that reasonable?
I think Jos would probably echo some of what you've just said. 97% of the workforce in Buurtzorg is female. And your question was partly also about gender. These teams also recruit their own new colleagues. And that might be a self-perpetuating sort of thing in that. And some of our HR professionals might think, not so sure about diversity impact elements of that, and that's a very important point. I think Buurtzorg are working hard with their teams to support them to also broaden their minds when looking at those parts of being a team. But to come back to the informal leadership, I think it is there is some risk of that. I think there's a bit of self-selection going on. Nurses who like to work independently or care professionals who like to work independently make their own decisions. They tend to be attracted by this model. But every so often there will be a bit of informal leadership stepping up. Now, up to a certain level, as I said, Buurtzorg is not about control. So if it works, if the team is happy, they will quite happy to let things work as they are. If it becomes an issue, then sometimes teams ultimately may end up having to be disbanded simply because that has become unworkable. But as I said before, this is super rare. And at some point, other care organizations in the Netherlands were sort of saying, yes, but Buurtzorg, very successful, but you wouldn't want to work there because you have to deal with all that stuff on top of your caring role, and they really put the pressure on to make sure you deliver sufficient hours and all that sort of thing. So Buurtzorg decided, okay, well, let's ask our workforce, and so they started participating in this Employer of the Year election that is countrywide, not just for care organizations, but for all organizations, and promptly won it 4 times in the last 7 years and came second in those other years. So I think the workforce absolutely loves working in this way. And yes, of course, every so often you may have a little blip that doesn't quite work out in a particular location or in a particular team, but overall you're delivering a great care in a great organization. So SDMI, it's interesting to watch how teams use that. So solution-driven method of interaction. It's a time, it's not rocket science, but it is a way of conducting meetings and conducting conversations, not just within the team, but also with your clients and with other parties, which is constantly focused on, okay, let's not dwell on the past. Let's actually focus on which options do we have to address this particular issue or this particular problem, and focus on solutions and which solution we can all live with so that we can move forward really, really positively. And when you have a well-tuned team, they almost use it naturally, but of course it doesn't come naturally. It is something that you need to get used to a little bit. But it really helps to take the focus away from. So it's almost the opposite end of a root cause analysis. Actually, really focusing on a way forward. We help teams here in the UK, therefore, adopt that method as well. It's a half-day training, or a day at the most, and then a refresh in a month or two, just to remind everybody what the Buurtzorg way of making decisions really is all about, and on the whole, people take it on really quite quickly and quite easily. Role of the coach, and what is the background of a coach? In Buurtzorg, all the coaches happen to have a clinical background. That's not because they are being asked lots of questions around how do I treat this particular condition or that sort of thing. It has more to do with they understand what it's like to be in a self-managed team and deal with the demands of delivering a good home care. They actually, they're called coaches, but they, on the whole, coach in a very different way as your typical coach. So it's not so much about the person and the self-reflection and what do I feel. No, they are also relentless in this solution-focused approach. So how can we move forward? What alternatives do you have? Let's explore. Let's try this now. And as I said earlier, ideally they only respond to requests from teams. But if they, of course, they see the performance information from the computer system. They can see their teams and see how they're doing. And if they see one team dropping off slightly, or more than slightly, they might just think, well, let's just give them a call and see how they're doing and whether they need any support with anything, whether everything is still going hunky dory. Does that answer your question? It was yours, Neil, wasn't it? Yeah. Can't read my own handwriting. Addressing individuals' poor performance. Yeah, that's a tricky one. So this is with the team initially. So if one of your team members is not pulling his weight or is struggling, what you need in a team is really a safe environment and the trust that you can have these kinds of conversation in the team about the team performance, but also about individuals' performances. Or even if I go in the afternoon and I see, I don't know, I'm just making it up, how my colleague has dressed this particular leg ulcer, and I go, it's not quite how I would have done it. To be able in a team to have a conversation with your colleague, say, hey, I went to Mr. So-and-so and I noticed this, and I'm just curious to find out why you did it that way. And being able to have that conversation safely so that you can improve performance. And I think what you see in Buurtzorg teams, because they are self-managed and because they've been given really the responsibility to do this well, they respond to that well. They see the team performance. This is ours, guys. We need to make sure that we do well. So they don't lean back. They don't wait for somebody else to put this on the table. No, they see it as their own responsibility to contribute that and achieve good performance overall. Now, of course, there's always a possibility that somebody really doesn't quite pull their weight or struggles for whatever reasons. Maybe there's also stuff going on in the background. And the teams, it's up to the teams to have regular supervisions internally with their individuals, and they can decide how they do that. So every team can theoretically do that in different ways, but of course they share on the web, what works for each and everyone, so that you can learn from that. But if there is an individual still struggling, then they will have formal performance conversations in the team. They may involve the coach to help in that process. And in the Netherlands, it's just as regulated as it is here. If ultimately someone doesn't quite perform and can't turn it around, and therefore needs to leave the organization. And this is very tightly controlled in the Netherlands, that this is done in a fair and transparent way. And the teams will manage that up to a point, and the coach will help them increasingly as it becomes more and more complicated and more formal as well. Yeah.
12 people.
You're right. And the same with those intervisions or performance appraisal type conversation tends to be 2 people, for instance, that have a conversation with 1. But again, you wouldn't do that around a table with 12. You're absolutely right. That might be a bit much. Yeah, there was a Manchester question. That was about the legal framework and statutory arrangements around this. So, clearly, although in the Netherlands there's just as much regulation and rules and regulations as there are here in the UK. They are different here in the UK, and that's partly what we're trying to find solutions for with our clients. So around regulation, it's relatively easy because the CQC is actually not that specific about how you deliver care. They're much more specific about that you can evidence that you think about the 5 headings of what good care looks like, and well led and safe and that sort of stuff. And actually, in all of the aspects, the Buurtzorg inspired or the Buurtzorg teams tick all of these boxes. And generally, when we engage in conversations with your regional CQC person, they are very open to this alternative way of delivering care. Sometimes ticking a particular box might be a little bit tricky, especially in the well-led front, because who is the leader in a self-led team, right? It's a bit tricky. So usually there is a registered manager somewhere in the organization. It could be the chief nurse, it could be anyone who takes on this formal role and has to satisfy, especially the CQC, a little bit of an oversight role. But we try to make sure that that person doesn't then become the manager in the old-fashioned sense, because that would defeat the whole exercise. So from the CQC side, I think we're on the right track, and we are increasingly having conversations with higher levels and speaking now to the new models team of the CQC as well. On the funding side, it's a bit tricky still. We haven't quite cracked that nut yet. Where health funding and social care funding comes together, awful things might result. Especially after the first 6 weeks of reablement funding runs out and the eligibility process kicks in. Again, we haven't quite cracked that nut yet, and some of our organizations various organizations have made different decisions in how to deal with that. But what we hope is that, similar to what Buurtzorg had to do over time in the Netherlands, is increasingly show that delivering care in this particular way will lead to better results, and therefore the funding needs to reflect that kind of care delivery. Now we are engaging with the very top at the moment. We are seeing Secretary of State Matt Hancock in 2 weeks' time, and this will definitely be one point on the agenda. I don't think he will resolve it there and then, but we will certainly engage in a conversation with him about this, because as he has noticed in his own backyard in West Suffolk, we actually have a pilot going, and he's MP for West Suffolk. He has seen the pilot, and he was hugely impressed. And of course, we used that opportunity to flag this up with him. So I hope that Manchester that answers your question. Great. Then the role of the board. Well, in Buurtzorg itself, there is a supervisory board. Well, you can imagine that they are very hands-off, because even management itself in Buurtzorg is very hands-off. So they're much more focused on the next wave, the next thing that they can do. The most recent thing that Buurtzorg achieved was a large multi-year contract with one of the biggest health insurance firms to actually start investing in prevention and early intervention. Of course, it's already part and parcel of the Buurtzorg way of working anyway, but to do this more and more and make this more a community focus is a massive step forward, and is something that Jos has been working on for several years. And is that kind of thing that ultimately at the top of the organization tends to occupy them much more than you know, how many teams have we got, or that sort of thing. So does that answer the question? It was your question, wasn't it? Can't remember. Anyway, it was a web question, wasn't it?
Yeah. Ben, and then I've got an idea for how we finish.
So you talked about one of the issues in the UK is the management issue.
Yeah.
I was interested to understand a bit more about that, and also, I mean, my understanding at the moment, you're in the UK, you start out trying to enable other people, but now you are looking at actually taking on contracts yourself. And whether that was simply because it's too complicated to change somebody else's culture. So I was just interested in trying to understand the challenges of that.
Yeah, very good question. Yes, it is hard to transform an existing organization, and especially a part of an existing organization. And even when the top is fully bought in, there's still many other parts of the organization that don't necessarily either get it or simply they've been working in a particular way for all their lives, and you can't expect them to let go of all of that all of a sudden. So it is really hard to see some of those pilots thrive. Usually, as I indicated, it's not that they struggle because they don't get the self-managed model or they don't get the care delivery model. What they struggle with is that the rest of the organization almost works against them 9 times out of 10, not deliberately, but simply because the organization does what the organization does. So we've been doing this now for a couple of years, 2 or 3 years. And we are beginning to think, okay, maybe there needs to be an alternative offering to the health and care system in the UK. Maybe as Buurtzorg, we need to set up our own care provider organization and offer perhaps partnerships to existing care providers. To say, okay, well, we certainly know how this is supposed to work. We don't come with all the baggage and the history that you come with. We don't come with all the other services that you have to provide as care provider. We can focus on what we do best, and perhaps we can work with yourselves, take on that part of your obligations and deliver it through our method. It's extremely early days. I mean, this is literally blue sky thinking stuff still. But Buurtzorg in the Netherlands the board has in principle said that they're interested in exploring this. So we're currently doing some planning work around this, what this might look like.
Provider with profile.
I think that is the most likely strategy for us. I don't really see us coming in and become a Virgin Care, for instance. I don't see the point in that. I think that would be defeating the whole purpose, and it would also go against the grain of I think the culture and the objectives of Buurtzorg itself. Yeah.
What I'd like to do is spend a couple of hours. What I want to do is try and surface a bit of what this means for you, because it'll be setting off all sorts of thoughts about your own organisations, your own management style, your own teams, and how you work. What I'd like to do is partner with somebody in the room and just share with them for a minute or two each, what you think this is. What Paul shared with us today, where it's hitting you and touching you, and then we'll hear back from some of you in the room. So if you could just find a partner. Ideally, something you go. Okay, you've been thinking about how this has been hitting you and what's been relevant to you. Just love to hear back from anybody who's not spoken yet, and ideally some women.
Nicola, thank you. I've got loads of questions, but I'll pick my kind of top one, which is. Has the model been adapted for people who have a social care but not a nursing requirement? So where there's no nurses involved? So we provide 24/7 support to people with very complex needs, but they don't need nursing support as such. So we would work locally with multidisciplinary teams to source that. So
very quickly, Paul, and then we'll keep it flowing here.
Yes, it's the short answer. So if you want to come to me afterwards, I can give you some more detailed examples.
Yeah, Paul's hanging around, so that's good. Anything else from you, Nicola?
Well, just how are commissioners responding? Because they'll be, impressed by the headline of reduced costs, but then will they actually go for it and commission it? Because they're just wading in mud and don't like stick their head above the parapet and do anything differently.
Yeah, I think that's an excellent question. And through those pilots, we try to collate sufficient evidence to get them to come across, I think. We are now increasingly having conversations with commissioners responsible for large areas who are beginning to think, actually, there is something worthwhile in this, and let's take this seriously. But up to now, it's been largely driven from the provider organisation. And I think part of what I said about having to bring the rest of your organisation along actually goes for your commissioners as well. In that process, you need to bring your commissioner along on this, because it's often the commissioners who drive 50% of the behaviours of organisations. So without their buy-in and their understanding of how this changes life, I think you don't get the full benefits. Yeah, so good point.
Judith.
So we had a bit of a chat about the digital underpinnings and comparing and contrasting what we think. You can say I can't.
So whichever way you want
Buurtzorg has and which enables those teams to be operating. Comparing and contrasting that with the digital underpinning that is still in that in the UK and how that works. I'd be interested how that works in the pilot. And then there was we also had some discussion about really appealing this idea of self-managed teams, how group of professionals, how you can create that and make that work in big decisions. That was your point, wasn't it, about little group of rebels over here? Is that what it becomes? Is that do you want to add in?
I like that chart with the standard org chart, everything Sunday chart, and then the one with the little cells buzzing around on the right hand side. I thought that was an appealing picture, but getting that in reality is a different thing. To get that permission to do something non-conformist.
Well, that's still the challenge, I think, to be honest. That scale is not an issue. I think Buurtzorg has evidenced 14,000 staff all working in self-managed teams.
Any points from our colleagues?
Craig, can I just? Sorry.
Yeah, hi. Can you hear me?
Yeah, we can.
A question from me. My name's Bernie Garner, and I think it's the analogy of what you've described as a very medicalised approach in the teams that are developed. And although that works in the Netherlands, what I'd be interested in to see is how that would work in practice in the UK. So we are cautious about medicalising care because social care hasn't been a medicalised model of delivering care. So there would have to be a significant cultural change in the education of the nursing staff to take on these roles. And also to educate what a social care worker's aspirations could be. So I think that's one of the challenges I see, that the education side of the emerging nursing workforce have to understand the stepping away from just a very medicalised approach to care. And it's, one of my colleagues here pointed out, it's very, the NHS, very, what's the word? Hierarchical. So, and how do we step away from that?
I think the other point that Gina made was about bureaucracy within the NHS, local bureaucracy to put a care on the ground.
Thank you. Two quite powerful questions and contributions there, Paul. So one being about do we really want nurses doing this? And two, is this in the nightmare that is the NHS? How do you make this work in all reality?
Yeah, we don't have a ready-made answer for that. We're trying to convince by doing and by demonstrating that it can work in the UK context, rather than arguing about it too much. So I think that's definitely the reason why we are pursuing all these various pilots with the various partner organizations. But can we overcome the tendency to be command and control that exists in our UK world? Time will tell. Watch this space, or work with us to try and achieve it. In terms of the medicalization of care, we clearly want to go back to where a nurse was looking after much more than just the medical need of a particular client. But we are not strictly as a nursing model. There are various teams and pilots where the teams actually consist of both home care workers and nurses. There are teams where there are also social workers involved. But I do think that what emerges from some of these pilots is that a redefinition of some of these roles is perhaps what's called for. but it's too early to be too firm and too prescriptive about that. But there's lots of emerging learnings from these various pilots.
Then we'll just do some winding. So the two Ians, Ian Merrill and then Ian Hempstead. Assuming you want to. Yeah, Ian, yeah.
Just want to go back to something we touched upon, which was, it seems to me, the success of the self-managed team is built on the staff's ability to have candid conversations with each other. How do you develop that through your model? I assume everyone doesn't arrive already. How do you inculcate?
Well, we start from the point that we believe that everybody comes in, A, to do a good job, and B, that everybody brings to the table a lot more than just their profession. And thirdly, that they're all coming as an adult. So we appeal to everybody being an adult, responsible adult who makes important decisions on a regular basis in probably non-professional context, buying houses, getting married, having children, all that sort of stuff. And we appeal to the fact that everybody actually is able to come to decisions much more broadly than just having to do with your work. So once you start from that principle and start to appeal to those principles and allow people to also build on those skills and personality traits that they bring to the table, accept difference, accept that people are perhaps in different parts of their lives. Some may have young children and needs to be at the school gates at a particular time. Others sit in are in a different phase of their life. Bring all of that together. I think is really important that you allow these differences to be accepted and start from that starting point. That isn't to say, as I alluded to before, that having conversations around performance or having conversations about opinions or how to deal with conflicts isn't sometimes a very tough thing to do. And if you were to talk to people operating in Buurtzorg teams, they would probably tell you 9 times out of 10 that they find that the hardest part of their work. But they still would prefer that many times over a situation where they don't have time to speak to their client and have to rush from client to client to client, or have to explain to their manager why they spend 10 minutes longer at Mrs. X's home. Right, so I think on balance, it really pays off tremendously for them.
Do the teams, or could the teams have autonomy over the income which is sort of earned by them attributable to them? So let's say the team collectively decides we want to spend money on this training, or we'd like to award ourselves a bonus above our normal pay. Is there any autonomy over what you earn in the team?
No. Not in a Buurtzorg organization. They have their budget for training and education. They have their budget for their office. They have their budget for some social activities. That's the only side that they need to manage money-wise. If they do well, great. If they are struggling, well, they don't really have to worry that will eat into their earnings or anything. Buurtzorg it's a care organization. It's not a money-making organization, and that I think is re-emphasized by not emphasizing that aspect of life. There's absolutely no bonus culture. No, not at all.
From the webinar.
Okay, yeah. So there's been a few questions come in around coaching, and lots of which I think we've kind of dealt with anyway. But the couple of strands that I'd like to pull through are around what happens when it goes wrong from a staff management perspective. And I think one question has been around what does this model do with absence rates, staff absence rates? And the other quite cool question, given the context we're in, is particularly from Jos's perspective. How does this model change the role of the CEO himself as opposed to the board?
Let's just do that last one, because that's quite a new question, I think.
Yeah,
the Jos role.
The Jos role.
Yes.
It's a very good question, and clearly, as a CEO, you don't have a big planning mastermind strategy role in an organization like that. You're much more or at least Jos as a person is much more relaxed about letting things emerge and letting things happen. So to have that kind of ability to let go a little bit of where the organization is taking you is something that will benefit this model where you allow parts of your organization to find local solutions for local needs. On the plus side, that allows you to focus on different things, innovation, really doing stuff that benefits your client group longer term and more widely. And it actually, some of the leaders who have also adopted this model in existing organizations in the Netherlands, they tell me that it actually frees them up because they are much less focused on performance issues, headaches around conflicts within the organization or perhaps outside the organization or things like that. That doesn't mean that Jos doesn't have his fair share of headaches every so often. Dealing with health insurance companies, regulators, of course, they keep you busy still. I think the way Jos has built his organization has allowed for him to have a much more peer-to-peer conversation with every single member of his organization rather than feeling that he has to be the leader and show the way forward. Using modern technology and building an organization that is super flat combines two quite strong elements to something quite powerful, I think. And is it for everybody? Probably not. But I have there's plenty of good literature out there and some great videos on the web, by the way, of a hugely diverse organizations delivering very different services, encapsulating a lot of these principles themselves. There's a fantastic video of a submarine commander who has adopted this. We can send you the link to it. It's 10 minutes well spent of your life watching that video. There's some great books on this. There's the Ricardo Semler book called Maverick from the 80s, but still super relevant. Who built his organization or transformed his organization actually, who built large air conditioning units, pumps and all sorts of industrial stuff in an organization being largely based on self-managed principles. And there's lots of exciting stuff out there that I would thoroughly recommend that you have a look at, because principles behind this can be applied in all sorts of unexpected areas.
It sort of drives against a lot of the notions of what leadership is in our culture, which is, I as a leader I'm going to drive this organisation to the next level, and you're going to follow me, and all of that, which is very much I think quite an Anglo-American view of leadership, and we like leaders that are very clear about where they want to go, and leaders that stand back and let it happen are not always regarded as good leaders. So it's very interesting to just contrast this approach that Jos de Blok has adopted with what we see, what our notions of leadership are that we carry with us in our day to day. Final contribution, then I want to let Paul wind us up at the end. So anything else from anybody else, and then we'll go into wind up.
I just saw in the WhatsApp group, so for someone else called Lance on the WhatsApp group.
Oh, right, okay.
And they've asked, two people have said the same thing about pharmaceutical companies. Has there been any pushback from pharmaceutical companies, or what's the relationship? Have they impacted? And in a personal one, because I was just something you brought up about insurance companies, I was wondering, is there any way you could demonstrate that preventative model? Could you get more insurance companies, even in the UK, to buy into it? Would that be an easier way? Because longer term, social care would be cheaper if people had a more holistic approach. Is that a way you could then demonstrate the impact, even for the NHS, as cost saving rather than business cost rather than
Yes, I think it's a short answer. Whether that will be our going in position in the UK, I'm not sure. I think we have some interference from Manchester. I think Buurtzorg being not for profit is sit probably slightly less comfortably with first and foremost focusing on private insurances in the UK. I think Jos's passion, he's always been an admirer of the UK district nursing model. That's also why we are now thinking of coming here more as a provider organization. But demonstrating the impact is ultimately, I think, key in all of this. And yeah, we're working on different fronts and trying to achieve that.
Gina, did you want to come in? Because I'm conscious there was a conversation point there.
Sorry, it was just something that occurred to me around this particular model in terms of medical indemnity. We have struggled with indemnity purely for the fact that we don't have a regular GP model, partnership model, that we are a social enterprise and we do outreach work and all sorts of innovative things. And that has caused a lot of headaches for us. We've found our way through, but I just wondered with the level of autonomy that the teams have in terms of leadership and being nurse-led, how that affected medical indemnity and going down that medical legal route when something goes really wrong. I know you said about captain the submarine and the air conditioning units. That's quite controlled. Health isn't. People are unpredictable and their medical conditions are unpredictable, and sometimes individual responses to that.
Yeah. Well, health insurance or indemnity insurance-wise, our client organisations in the UK haven't encountered any issues with that so far. They've always managed to address that. If you were to set up a brand new organization working in this way and having to find insurance for that, I don't know whether you would encounter problems. You might well be right there. So I can't really comment on that. So yeah, ultimately you're right. There are always risks involved in delivering health and social care to individuals. What we have seen from 10 years of Buurtzorg is actually that this model delivers better outcomes, fewer complaints, fewer things that spin out of control. Recently, Buurtzorg was inspected by the regulator and received top marks across all categories, which has never happened before in the Netherlands. So it is a scary jump in the slightly unknown, I think, for a lot of UK organisations to think quite drastically and revolutionarily in a different way. But I think what we're seeing from Buurtzorg as an organisation, that it can be done.
Moment where we're going to come to a close in a second, and I'm going to ask Paul just to kind of leave us with his most powerful message that he wants to leave ringing in your ears. Before that, I just want to quickly just give you a couple of reminders and notices around Social Club, because I think once Paul's gone, thank you, Ian, you'll want to get on your way. We've got clubs in January, we've got two events in London, one in Manchester. We're soon going to be sending out our survey as well, our annual survey, to ask you about what you're thinking and what you're needing about next year. That's going to come out quite soon. Please fill it in. It gives us loads of ideas and inspiration for what to do with Social Club. There's going to be the website's being redone as we speak, and will be relaunched in probably toward the end of the month. That's going to be about making registration and getting on events and things a lot easier. At the moment, we do it all by email. It's a bit tedious, and it takes up a lot of time back at base. So we're trying to make that a little bit more smooth and autonomous and smooth functioning. So Joe's going to be in touch about that very shortly. So expect something on that as well quite soon. It's just about making things a bit simpler and a bit more slick and easy for you all, hopefully. So they're just the notices, really. Anyone who's new to this and trying out today, if you want to chat afterwards, then I'm here, and feel free to stay and talk. And if you want to come to another event and see what it's like, then let me know. And and then Christmas will soon begin. That's the notices. Very quickly, Paul, would you mind just kind of bringing this to a rousing?
Well, I hoped that I've given you plenty of little nuggets to take away. So I don't have one all-encompassing message for you to take home. What I would say is that personally, I feel privileged to be able to work with an organization like Buurtzorg. It's hugely inspiring, and I hope that some of the inspiring, some of the inspiration that Buurtzorg brings you will take home with you, and will help you think about how you organize your organization and how you deliver your product, whatever that product might be. If you want to know more, my details are on the slide, and contact me by all means. Lovely to meet you this morning, and hopefully you found it useful.
Thanks once again.